trying to retire. I retired from the University of Wisconsin in 2016 and then got this job. So I hope the next one works better.
You want this one to take. That first one.
Absolutely.
Just
Absolutely.
right.
I need to take.
Okay. Well, if you are ready, if you want to share your slides, we will get started.
All right. I will.
Because we want to leave lots of time for discussion. So, and people, it looks like people are rapidly joining us, which is good.
That's great.
Okay. Hi, everyone. I am Dr. Susan Fenton, and it is both an honor and a pleasure to introduce our speaker today, Dr. Patty Brennan. She is the director of the National Library of Medicine at the National Institutes of Health. NLM is a leader in biomedical informatics and computational health data science research and the world's largest biomedical library. Dr. Brennan holds a Master's of Science in Nursing and a PhD in Industrial Engineering. She is a fellow of the American Institute for Medical and Biological Engineering, an elected member of the National Academy of Medicine, and a fellow of the American Academy of Nursing, the American College of Medical Informatics, and the New York Academy of Medicine. Please join me in welcoming Dr. Brennan to what I'm sure is going to be a very enlightening talk and then discussion today. I'm so excited. Dr. Brennan.
Susan, thank you very much. And thank you to all of you who are giving up what I suspect is a bright and sunny, but maybe boiling hot day to be inside for the next hour. I'm particularly excited to bring this perspective on open science and public accountability to a discussion about the National Library of Medicine and public policy. We're going to discuss quite a bit about how the National Library of Medicine both shapes and is shaped by policies, because as a federal agency, as a public agency, we have many public accountabilities. Excuse me. I will, of course, focus a little bit on generative AI and AI in general, because that is becoming an incredibly important policy issue and merits its own discussion by itself. And then I have a couple of questions already posed and hope to hear more from you. I understand you can post questions in the Q&A and they will be moderated as we get to the discussion. By way of introduction, I grew up in West Philadelphia, and I'm the second eldest of 10 children. So I learned how to speak very fast and very loud. And I may be speaking faster than you can listen. Susan, I don't know if you've recorded this or if you routinely record this. It's perfectly fine to me that it be recorded, but also my slides will be available to you after I finish the talk, and they can be distributed and shared widely.
We are recording you. All of the papers have been signed.
Terrific. Okay, we are recording. That's great. Just to let you know that the slide deck that is available through Texas is actually has additional slides in it that I will not be speaking to today, except I did hear that there may be a couple nursing people in the audience. So I'm going to speak specifically to my base profession of nursing. So I'm a nurse and an industrial engineer. I spent my career looking at ways to make technology useful for people. My personal avocation has been making sure that housing is both safe and sustainable and food is available to everyone. So when I was retiring the first time, as I was explaining to Susan, I was going to end homelessness in Madison, Wisconsin, where I lived at the time. Appalling that a beautiful city like Madison has a terrible homeless problem. What I realized, though, as I was approached about the job at the National Library of Medicine, is that we define health through literature, through data repositories, through the research that we do. And one way to improve both the housing and food sustainability, which are considered social determinants of health, is to oversee the development of the literature. So this job actually fit in with both my personal passions as well as my professional interest. While at the NIH, I have led a laboratory in the National Institute of Nursing Research on virtual reality. The advanced visualization branch of the NINR uses virtual reality as a research environment to better understand self-care and self-management, two concepts that are really important to nursing. But today we're not really here to talk about nursing, but you'll get the flavor all the way through. We're here to do three things. I want to talk about the impact of policy on the National Library of Medicine, because we actually do respond to and are shaped by public policies, but we also contribute to policy either directly by helping to shape national policies or organizational policies, as well as to contribute to those of you who are studying, who are learning to be policy analysts, because our resources will be partners with you for your entire career. And I want to spend a little bit of time helping you think about pathways to engage the NLM in support of public policies that enhance the impact of your science, whatever your science is going to be. It is a critically important fact to remember that science alone does not change health, does not change society. Science embedded in informing and expanding policy is what changes society. So we always get to a point, especially as nurse researchers, of creating interventions, but the ability of those interventions to have an impact requires that there be a policy framework around them that enables them to happen. When I was first studying the use of participant patient level computer networks, which were then bulletin boards in the 1980s. We had 110 baud modem, and we had a WISE 30 terminal that had green colors, only text on it. When we tried to bring those tools into people's homes, we got lots of questions. Did the Nursing Practice Act cover nurses' engagement with people over networks? What was the self-care responsibility? What if the technology failed? Policy shapes our ability to do research and our ability to have the impact that our research deserves to have. So I want to put on the table, we're partners with you for your future, and we'll continue. Now, I'll begin by taking a look at the types of policies that affect NLM, and I want you to pause for a minute. Actually, I'll back up for a minute and ask you, when I'm using the word policy, I want you to think for a minute, what's coming to mind? Are you thinking about the Hastings Institute or the Brookings Institute? Are you thinking about an executive order from the government? Are you thinking about the policies in a hospital that drive how one administers a medication or washes one's hands? Think for a minute, what does policy mean? Because I'll bet across all of you listening today, there's different definitions of what policy is. When I worked with my policy team to discuss this presentation, they enumerated for me what you see on the screen in front of you. Policies emerge from legislation. There are administration policies. For those of you who remember your 7th grade civics, we are the National Library of Medicine in the executive branch of the government. So there is also the legislative branch and the judicial branch. We are mostly influenced by administration policies within the executive branch, but there are also departmental policies within the Department of Health and Human Services. There are public policies that NIH promulgates that we'll be talking a little bit about, the data management and sharing policy. There are policies within the NLM that we establish to make sure, for example, that our deposits to our sequence databases are managed in a systematic fashion. Scientific communities suggest policies and direct policies that can shape the work of others. Scientific journals and societies are really quite important partners in policy. We both work with and are influenced by the way the journals promulgate work. One of the major accomplishments we had over the last 20 years is to get the journals to require the inclusion of a clinical trials number for any clinical trial that is reported in a journal, so that we're able to track, that is, connect the information that reported in the paper with information in our data repositories. We also do work more and increasingly with international organizations, and policy takes some really interesting dimensions in the international arena, where local country-led policies trump any international agreements, and many times policies are sharply influenced by the culture of a country, its ethnic origins, its economic values. So international policy is really a matter of negotiation across equals rather than dominance of a single person. There are specific policy and legislative areas of interest to the NLM. We're very interested in policies related to the literature, open access and public access policies. We're very much interested also in information policies, privacy, for example, and the rights of individuals to control their clinical information. Data management, particularly secure data management, and this takes on international dimensions when we talk about data sharing across countries. These policies are critically important. We work with the WHO and we work with many international bodies to make sure that the policies foster the open science engagement that the NIH and the United States government is taking forward. We work closely with the health IT, health data standards industry, and health data interest groups, because the policies about health data affect the data that is ultimately available for research. In addition to that, the National Library of Medicine helps to provide the standards that help codify clinical language. We work and are very interested in policy that relates both clinical care and public health. During the pandemic, we spent a great deal of time trying to improve the engagement across public health entities for data sharing, recognizing that states had many rights over those policy data sharing activities. Science and research policies but we also are very much shaped by appropriations. And at this very minute, we're looking a little worried at the 24 budget. It's looking a little tight to us. And also government operations. So we have a broad range of policy that we are interested in. The policies that can specifically impact what the NLM does are data science and open science, and these policies arise from a number of areas. The recently released NIH data management and sharing policy requires investigators to have a plan for sharing data. All data doesn't have to be shared, but if it will be shared, it has to be shared across appropriate protected areas. Open data is a concept that describes a perspective by the U.S. government to open the resources of the government to industry, to science, to society for better leveraging of the federal dollar. Open data policies can sometimes conflict with things like the data management and sharing policy, where we respect the rights of an individual, the rights of a participant to not have their identity disclosed. And as I indicated earlier, international engagement around molecular and clinical data is becoming front and center because we learned through the pandemic, viruses don't respect country boundaries. And to understand the progression of a virus required that we be in close contact with our colleagues in South Africa, our colleagues in Europe, and our colleagues in Asia. Emerging analytics bring on all sorts of policy questions, and many times the policies lag behind the technology. So I'll be speaking today about transparent, trustworthy, and trustable AI, which are aspirational statements rather than, frankly, anything that we can achieve through policy or science. And scientific communication is a particularly critical area for a library to focus on, including the public access responsibilities. And I saw we have a question about how we're going to manage public access, data sharing, how we can support data sharing. It's not an intuitive skill that all researchers have. And even the way we manage the collection at the National Library of Medicine. We protect our materials over time. We make them available at no cost to anyone in the world who can use our resources. We see ourselves as a knowledge hub that serves and shapes policy. And on the right-hand side of the screen, you see a number of different circles, and each of those depicts a different part of the NLM operations. We have a biomedical data and tools to use that data, whether it's a blast search or the sequence read archive on the right-hand side around 1 o'clock. Moving around the clock, we have some information that's directed towards consumers, and some of that information is actually driven by policy. For example, making transparent the records of clinical trials so interested parties can actually refer themselves to a trial and not be held only to referral by their physician. The library maintains resources, as many libraries do. We are not a lending library, but we are the library of last resort, so that if a journal article or a particular monograph cannot be found elsewhere, we look through our records and share with the person who needs to have it. Increasingly, that's done through interlibrary loan resources, something called DocLine, but it also, people actually can come into our building now and look at our holdings, which they do. Continuing around the clock around health data standards, you may not be aware that the National Library of Medicine is the federal repository for clinical data standards, including SNOMED, LOINC, RxNorm. We also have other clinical data services, such as the Value Set Authority, that helps to create the packet, if you will, of cost or value activities that a hospital wants to bill for or demonstrate progress on. MESH is our literature terminology, and the CDE repository is a strategy that we're using to increase the use of common data elements in research. At the top, though, we do conduct research and we hold research literature. So we are best known by our literature resources, PubMed, PubMed Central, and the Medline collection. We envision a future where we will be interconnecting data sets all across the world, not just those held or stewarded by the NIH. So you see on the screen in front of you the National Center for Biotechnology Information. That's a part of my operation at NLM. But we also have the Framingham Heart Study, or the Cancer Moonshot, the Brain Initiative, the All of Us. These are programs that are funded by the federal government, are initiating change across the world, and are understanding and caring for people with complex illness. And we recognize that to leverage these investments, we need to build not only deep data repositories, but interconnections and interoperability between them. An example of how we're doing that is something called the Comparative Genomics Resource. If you look at the left-hand side of the screen, you see the NCBI infrastructure, some of the terms you've already seen, BLAST or our visualization sequences. Some are maybe new to you, like the transcriptome and genomic annotation. That's how we provide value add to our data. But we recognize that our data are used, they're run in algorithms, they're created in ontologies, or tools are built with them around the country. So instead of building all of the resources inside of the NLM, Look at the yellow lines. We're building partnership resources. So model organism studies, which are ways that researchers take a model, a non-human model of an organism to be able to study a human process. They may build tools that will operate on our data, and we want to make them available to the community as a whole. So our strategic goals is to first and foremost to promote our data and tools resources, but also to integrate our content with the community. And you see some of the strategies we're using for that. Now, we don't know how to do all of this at once, so we conduct research. And the National Library of Medicine spends about $100 million on research every year, some in the extramural community and some in the intramural community. Our research portfolio is quite large. In our intramural community, in our intramural research program at the NIH, we study evolutionary genomics, we study natural language processing and statistical methods. We have a particular focus on networks, gene regulation, and chromatin within the NCBI. So we have special focuses on certain kinds of data that will become important to better understand and carry out the awareness of society's needs for human understanding and human treatment. At the same time, though, policies shape this. Can these data be shared? We have we've helped to shape from the late 80s the genome data sharing policy, which says from the beginning, genomic data should not be patented or held behind firewalls. It should be made accessible to the world. And we use our research portfolio to both test our strategies for making it available and to devise new ones. Recently, we've gotten very interested in clinical data and how we can discover more from about individuals when we can link their electronic health records with personal data from observations, as well as clinical and basic research data. This requires that we build not only the technological pathways to link this data, but also the frameworks that are going to allow us to do this protected in a safe way for individuals that maintains their privacy and promotes science. You should be hearing some themes that come over as I talk about the NLM and its way it engages with policy. An important area for policy implementation for the NLM has been the clinicaltrials.gov repository. This is an initiative that's over 20 years old, very much shaped by legislation, particularly the Food and Drug Administration's authorizing legislation. About 18 years ago, a decision was made that for clinical trials to be truly open, recruiting individuals from all sorts of stages of life and results being available to the public, we needed a centralized registry. So the National Library of Medicine built a registry called clinicaltrials.gov. Investigators provide their information, they register trials, and now studies that are funded by the NIH or designed to support the FDA application process must have their results reported within a year of the final individual participating in the study. We have over 400,000 studies now registered in clinicaltrials.gov. Some are active, some have been finished, and we have over 50,000 studies with reports. Sometimes we're the only place where the results of a study are presented because the study may never be reported in a journal. Hard to believe, but almost 30% of all the studies that are conducted never get reported in a journal. We are also trying to use research to help match patients to trials. So having information that says individuals are eligible if they have this, and this criteria still requires a human to read the criteria. So we're working with some of our researchers to build ways to interface the clinical trials registry and the electronic health record system. That's another way that we implement a policy to make clinical trials participation available to all. We are now, as everyone in the world is, looking into artificial intelligence mechanisms, particularly new innovations like ChatGPT, to bring these ideas forward and make better use of our resources. We'll be coming back to the artificial intelligence conversation a couple times in this talk, but I want to stop at this screen just for a moment to make sure that we have a common understanding. AI is actually old. It was the first implementation of AI algorithms was happening in the 80s. So it's 40 years old. We've had the AI winter where it all disappeared. We have computing schemes now that are more improved. We have better mathematics that led to machine learning. So we see a resurgence of AI right now. Machine learning is a very specific type, a quantitative type of approaches to understanding information from data. There are new approaches in machine learning that were referred to as deep learning, largely meaning, excuse me, that machine learning algorithms are then reprocessed multiple times to come to a more precise solution. And natural language processing, which is a type of artificial intelligence that draws from machine learning, takes aspects of words in a paragraph or words in a sentence. They may be semantic, what does this word mean, or structural, what word is next to each other. And through that, we discover, we understand, we interpret, and we can even generate information. Now, ChatGPT is a type of generative approach that takes an understanding of the frequency that words appear in a sequence with each other. How often do spaces appear? How often do letters appear? And presents that back in a colloquial interface with others. Why is ChatGPT so different than all of these other 40 years of AI approaches? Well, this has to do with three key aspects. The first, it's conversational language. And when you're talking about trying to see how public policy shapes the society overall, anything that is done in conversational language that helps people understand it is actually considered both of great value and it's updated more quickly. We also get creative outputs. That is, there is a generation, not simply interpretation. And what we've learned from ChatGPT and the other large language models is that often where we used to very tightly require a training data set with the application data set, the generative models are much more versatile. You can run a lot of applications over the same training data set. Very important to remember here, it's a public service announcement. Should you be using any of our publicly available GPTs, like if you go to OpenAI and sign into ChatGPT, all information that you deposit there is made accessible to the company. So you want to be careful that you never provide patient information or personal information about yourselves. Let me tell you a little about what's happening at the NLM with research in this area. Whoops, let's make my system behave.
There's never been a time in history where we've had so much access to science and technology as being applied to healthcare. And I think one of the challenges for the future is how to move things like biomedical informatics and artificial intelligence and data science into the mainstream of healthcare.
There is no one other than NLM who is specifically dedicated to biomedical information retrieval. We keep people focused on what really matters for health and advancing medicine.
Our research focuses on AI and machine learning. In the long run, what we really aim to do is to teach computers to read and understand scientific papers like scientists, to interpret X-rays or retinal images like radiologists at a speed and at an accuracy that's above and beyond human ability.
Medicine has been dreaming about having this ability to consult a large library of patient records to make better decisions. We've been thinking about this as a field for 40 years. Finally, with the support of the National Library of Medicine, we have established its feasibility, its safety, and long-term viability.
Every clinician has seen a certain number of patients in their clinical training, and they become very adept at that population. Machines, on the other hand, could be trained on data that is free of bias from different parts of the world, from different ethnicities, different age groups, so that there is an improved caregiving, therefore a better expectation on treatment and care.
What we've started to notice is that AI can be somewhat fragile. If it's given an unexpected input, it can give a very unexpected output. And so really the whole goal of our research is to understand how can we investigate where AI is fragile? How can we essentially break it so that we can understand how to fix it and make it stronger? But really it comes down to the ability to take what is theoretical research and apply it to healthcare and improve the treatment that we can provide patients.
I'm very proud of what we do in our research at the NLM. We study the fundamentals of how to fulfill information needs by individuals or to fulfill a need by a chatbot. We also use natural language processing. Image interpretation is particularly interesting, but you might not realize that sometimes that has to do with looking at medical images, or like Huang Yuan's work, it's looking at images generated by Google Neighborhood to be able to understand where are there green spaces and where are there crowded environments that might have more health problems. And our clinical work is expanding in this area also to include how to make clinical practice better, as well as how to build clinical algorithms. The NLM uses AI in its operations, and this is an interesting intersection of policy and operations, because we need to be transparent about what we're doing, but we also need to make sure that we maintain our operations with the highest level of integrity. So we use AI to improve access to the scientific literature, to manage curation at the speed of knowledge, because we have more data coming at us faster than we possibly can manage with humans. and to manage our terminologies most effectively. So let's talk first about how do we improve access to the research literature. In any given year, the PubMed receives over 1 million citations. Any search that happens almost always results in 20 or 30 pages of search results in reverse chronological order. But our researchers have used something called a best match algorithm using a learning to rank strategy. So if you look left to right with me, we take all the searches, all the articles that are in our PubMed citation repository. We take the number one query from the individual, and we make that syntax, we explode or enrich that syntax to extract all of the possible articles that might be useful. But then we apply this AI learning to rank algorithm to create a list of the best match. So now instead of presenting our results in reverse chronological order, we present them in a best match order. We found that our users like this. They're happy about it. They can find research. If you look in the upper right-hand side, you see best match or most recent. You can still pick the way you want to see your citations. But what we're also doing behind the scenes is evaluating, is this trustable? Are we over reinforcing use of certain kinds of literature and ignoring other kinds of literature? Because our policy perspective requires that we be egalitarian and that our strategies to improve the searches do not necessarily make it more difficult to find certain literatures. Another thing that we've been doing is using AI to make indexing automated. That is to apply those search terms to the articles. 1 million articles a year needing search terms. We used to do that with humans. It took maybe 18 months to get through a whole year's worth of work. So as you can imagine, we were always behind. But starting in 2022, after 5 years of preparation, we developed an AI-based approach to attaching mesh terms to an article that happens within 24 hours now, not within 18 months. But we are constantly, again, reviewing this to make sure we're demonstrating the quality of indexing for precision and recall so that we don't inadvertently bias access to the literature. We are also using AI approaches to support UMLS, or the editing of the Unified Medical Language System. The UMLS is a meta-thesaurus linking all sorts of vocabularies together, including SNOMED and LOINC, and it's appropriate to understand where some terms mean the same thing. That's called synonymy. That's the second bullet here. AI can support predicting synonymy within biomedical terms, and predicting this according to semantic categories helps us distinguish between homonyms. For example, you see here nail, which is a part of anatomy, and nail, which is a surgical device. Our current approaches lead to a slightly better accuracy, and our hybrid use of both of these terms are improving the semantic assignment. We continue to do research in this area, so we have new tools to build better systems and better tools. We are also recognizing that the policy initiatives at this point in time are very much focused on developing trust, not only trust in the AI, in the algorithm, but trust in the way it's used across individuals. So I'm going to take a few minutes now to talk with you about trust in AI and how the federal government is trying to promote this. What does it mean to really trust an artificial intelligence system or an algorithm? This actually rests on the broader trust in the healthcare delivery system or in the science community. And you're all aware that there's a tenor of mistrust about science right now. What's important to recognize with AI is that we need to consider not trust only in the result, but building a chain of trust from the initial questions to how we apply the data, how the model is created, and how it's applied. It's critical to remember we're trying to position AI as a partner to our users, clinicians or patients, but not as a replacement for them. So we have worked with our colleagues at NIST, at the National Institute for Standards and Technology, where they developed something referred to as the AI Risk Management Framework. If you simply Google NIST and AI Risk Management Framework, you'll find a lot of helpful resources. This is a federal initiative designed to improve the ability to incorporate trustworthy considerations all the way across the chain of the development of and use of artificial intelligence. When NIST talks about trustworthiness, they use the characteristics that you see on the screen in front of you. It is safe, it is secure and resilient. That is, if it gets unusual inputs, it doesn't incorporate those inputs immediately. It's explainable and interpretable. And that doesn't necessarily mean it's completely clear to any person who's using it, but each step along the way can be explained and be interpreted. It's built from a perspective that is privacy enhancement. and it is fair with harmful bias managed, recognizing that it's almost impossible to have an unbiased system because when you learn from an original source, you are already biased by the source that you're learning from. Systems need to be valid and reliable, and they need to be, of course, accessible, available, and transparent. The critical part is accountability, though. How do we show the accountability? Well, NIST has provided us with a framework that describes the process of building AI by first recognizing an opportunity or problem, creating an algorithm, acquiring a training data set, deriving nodes and weights, evaluating, retraining, evaluating, retrain. That means going through the cycle of looking at the nodes, looking at the data, go back and redo till you come to a level of precision, then transfer to a new situation and to use the output. There are different people involved in every one of these steps, and the policy implications in each of these steps is slightly different. So I ask you to walk with me through this system, to think as you're trying to build trust and transparency into an AI system. We are interpreting the policy, the vision of a trustable AI system into manageable steps. Your jobs are to think about what questions should be asked, when and by whom, and how do you document and communicate the chain of trust. Now, some of these can be approached on a technical level, but as this is a policy discussion, I want you to think about this from the perspective of the policies you're most engaged with and you're most involved with, whether it's policies about children and family or policies about technology access. Because one of the really interesting things about artificial intelligence and the emerging large language models that we're seeing is they're becoming domain agnostic. So we have to make sure we maintain the considerations of the original domain of the policy perspective as we go through the system. So first, recognizing the problem or opportunity. Who is involved in that? Well, often it's scientists, but we're seeing a rapid growth of community-engaged research and maybe even community-led research, which is, again, opening up new policy questions. We have privileged the scientific perspective, the, if you will, educated, authoritative perspective for federal dollars, but we're now actually re-examining that to make sure that the problem or opportunity is recognized from the perspective of those who have not only an intellectual interest, but an impact interest in it. Creating an algorithm requires that we understand how algorithms grow and repeat and sometimes embed unintentionally bias or thoughts of an individual developer. An algorithm that always leads to closed form solutions for a problem that could have multiple solutions is a mismatch. So there needs to be, again, a discussion between each of these levels. Acquiring training data. Now, often when we talk about trust and transparency in AI, the focus is on training data. And the focus is largely on, is the training data representative of the population where this algorithm is intended to be used? That's a very tall order to understand, first of all, how do we characterize what is representative? How do we characterize the population? And how do we make sure that this algorithm developed on population A is only used for people who are like population A? These all move into the policy sphere and move out of the scientific sphere. So even acquiring training data has a policy component to it. Deriving nodes and weights is a computational strategy, and frankly, I don't expect most policy wonks to know anything about deriving nodes and weights, but I do expect them to ask the right questions. How were these nodes derived? How many times were they tested? What kind of performance thresholds were you looking for? How do you just explain the way these nodes or weights have come together to create this solution? One of the key challenges of AI is that it results in, if you will, non-semantic solutions. That means it's not always perfectly clear what factors were posed to the system that led to or contributed to the answer that came out of the system. I'll give you a good example of that. In the 1980s, there was an expert system, an early type of artificial intelligence system that was built to determine people who are at risk for falls. And it had lots of questions. Clinicians in the room can imagine these: nutrition questions, balance questions, vision questions, lighting questions, environmental questions, lots of questions. When a clinician used this, the very first question they were asked was, does the patient look old for his age or her age? And if the answer to that was yes, then the person was deemed as being at high risk for falls. It made the clinicians crazy. Why? Well, because actually the system found that if you had just that one factor, is the person looking old for their age, you were at high risk for falls, because there may be many explanations. It may be lack of exercise, it may be poor nutrition, it may be any number of features that could be, cognition included, that could contribute to falls. But for the prediction of fall risk, it didn't matter. It just mattered if you looked old for your age. This was a deep problem for clinicians to accept because they wanted to answer all of the other things about the person to get the real answer, when in fact, the real answer came quickly. But knowing how to derive the weights and the nodes was required to explain to the clinicians why this was an acceptable approach. It's critical to evaluate and then possibly retrain and evaluate and retrain again. This takes time, takes lots of documentation, and it takes careful recording of, as algorithms change over time, what is actually causing the change. This is pretty much of a technical enterprise, but again, I say to a policy audience, you need to be able to have someone explain to you how this happened and why it happened. They're transferring to a new solution situation requires that we know the parameters and the boundaries of where a situation is valid. And then looking at the use of the output, which is often where clinical practice comes into play. Can I trust this algorithm to say that person's at risk and they should be put to the ICU, or that individual doesn't need to be hospitalized for that MI? The use of the output requires a very different framing of the earlier elements in this model. So as you're thinking about your role in creating a healthcare system that is supported by, embedded with AI resources, please consider this chain of trust as a way to demonstrate policy and action. The NLM is a partner in supporting and shaping public policy. As you prepare to go into your futures, I want you to hear that I think this is the most exciting time to be on the forefront of data. But what's happened with data is it used to be just something we used to get to the answer in research, and now it's a product of research. So we're looking to make AI-ready data sets, conducting new research to build new AI models, and advancing health for all, including through improving and using new modes of scientific communication. And I know one of you has a question about how we're using preprints, so we'll come to that later. In the sphere of open science and data science, we have to recognize that while this is a global phenomenon, it is very much shaped by US interests, including proprietary interests. I urge you to keep your policy eyes open for the next few weeks to watch for an executive order from the president about artificial intelligence and the new economies that are coming out of these kinds of approaches. I also urge you to think about how, and to take opportunities to discuss with others from different cultures within the US or different countries around the world, how these policies can and could be shaped. Privacy is a critical one, and yet privacy in itself varies across perspectives. We work very closely with tribal nations to be sure that the policy that they hold in terms of protection of health data is honored in the way we do research. So we must be mindful that policies around the same topic, policies may differ around a singular topic. We do this by keeping an eye, and within the National Library of Medicine, having an office on policy and legislative affairs. We have an Office of Policy and Legislative Affairs that identifies and works with me and our leadership to identify high priority and legislative needs. We provide coordinated approaches to policy and legislative matters so that we speak with one voice, and we help the NIH understand the meaning of some of these policies, because our special role in the NIH is communication, data, and analytics. Every other institute at NIH is interested in a body part, a state of aging, or maybe an approach to a diagnosis like cancer. We are interested across the ground, so we have a very large mandate here. We influence the development of policies in many ways. We engage stakeholders around the country and around the NIH. We participate in policy development groups. Please remember, the NIH and the National Library of Medicine do not set policy, but we provide education about policy. We commission studies on policy issues. We commissioned a study several years ago on data sustainability for a large data resource, and we provide resources and technical advice. We want to be the trusted partner with others as we move into an era that is driven by analytics, data, and most importantly, the needs of individuals, communities, clinicians, and scientists. I thank you very much for your time. I appreciate our chance to talk with you about the NLM as a trusted partner, as the policies that shape the future can be informed by knowledge. And I think we've left a bit of time for questions, so let me turn back to the moderators.
Thank you so much for this very incredible and dynamic discussion that you were able to present with us today. We are excited to be able to bring with you several of our student leaders and representatives from all 6 schools within UT Health here. And I'd like to welcome some of our student leaders on behalf of myself, Dr. McKay, and also Angela Gomez. We are the co-directors of the Quality Enhancement Plan, and we're excited to have brought this presentation here to UT Health System. And I'm going to invite our student leaders to be able to introduce some of their questions that they have prepared for you, Dr. Brennan, and we're excited to engage in this Q&A session. So first, I'd like to invite Samina.
Good afternoon, Dr. Brennan. It was a pleasure to see your presentation, and you answered a lot of the questions we had. But a quick introduction of myself. I am currently in the Doctorate of Nursing practice in informatics at the Cizik School of Nursing. My passion is integrating technology into healthcare, and that coupled with my nursing background fascinates me how much artificial intelligence is changing or revolutionizing healthcare. For the last 2 years, I have worked on an artificial intelligence algorithm to predict chronic kidney disease risk in a primary care setting. You did mention, Dr. Brennan, domain agnostic, but I would like to ask you, how do you foresee artificial intelligence influencing and changing policy at the National Library of Medicine in the near future? Thank you.
Wow. So that there's a couple of things embedded in that. Let me make sure that I understand your question. The first is, how will domain agnostic systems operate? And I want to take a couple minutes to speak about that, because I might venture a little bit into the area of advocacy here. And as policy thinkers, you probably understand how dangerous it can be to move from policy analysis to advocacy. Then we'll go on to what will this do at the National Library of Medicine, and how will it affect what we work on and how we work. So the first piece is we have built a healthcare system, and frankly, we've built a healthcare policy model that is very much anchored in domain specificity, whether it's cancer or aging people or children with autism. We have communities that anchor around diagnostic themes. And in the past, and to actually fairly recently, we built analytic tools that were highly embedded, highly informed by domain knowledge. And I still believe that many of the models that we have to replicate what we understand about physiology or sociology, so that our models should look like the phenomenon they're trying to characterize. Now that these large language models have come into play, we've lost that framework. So the large language models are actually surprisingly good at detecting semantic, or if you will, domain specific phenomenon, and creating text around domain specific phenomenon, even by using a very generalized data resource. So we're in a period of time that I think is going to require us to work with the philosophers and the theorists in our field to help us understand. Now, in the past, we used to assert a diagnostic area. We asserted this is what cancer looks like. We asserted this is what aging is. And then we built knowledge underneath it, assuming it was related to that assertional concept. Because if we claimed it was cancer knowledge and we studied it with cancer resources, it must be cancer knowledge. So, and now we have the opportunity to rethink the world, and to think in terms of symptom experience, to think in terms of behaviors, to think in a non-diagnostic fashion. But that, I think, brings specific policy challenges to individuals, because there is a certain rallying cry that comes around a thematic concern like cancer or children that then somehow disappears. So the challenge for you as policymakers is going to be able to walk in a world where you have to balance the thematic concerns or the recognizable name, children and family. We have a general understanding that means little kids. It doesn't mean adult families. A recognizable name, and yet the knowledge that might be relevant may come from many, many areas. So the bottom line, I believe, is going to be the need for policy analysts to be able to draw from a wide range of knowledge in an efficient fashion. Now, what is this doing for the National Library of Medicine? Well, one of the first things is we hold 35 petabytes of sequence data, 35 petabytes. Actually, when we moved it from our on-prem computers to the cloud, it took 7 weeks to move. and it brought down the internet twice. So this is a huge amount of data. And it is considered sequence data, but sequences at one time, our understanding of how sequences relate to structure and function of a human body change over time as we begin to understand the sequences more. So organizing the sequence information in a semantic fashion is increasingly difficult. Actually, even labeling the same gene across multiple species has proven to be a challenge. And that's where the comparative genomic resource is coming into play. So the National Library of Medicine is moving to build, if you will, data resources that can be examined by a number of different perspectives. And rather than privileging one perspective over another, we try to recognize the relationship between perspectives. What does that mean from a policy point of view? Well, a couple things. One of them is that it's a lot harder to rally around generalist approaches to studying a problem than it is to rally around specific ones. Kids with genomic disorders, oh my gosh, that's like, everyone understands that. Sequences that might appear in a child and a cat, that's much more difficult to get interested. So we from our perspective, we need to keep our foot forward about how we as a generalist library support these various approaches to understanding policy questions. Secondly, we need to be able to ingest policy considerations so we protect human data from non-human data in different ways. Now, in a health resource, protecting human data from non-human data in different ways is fine. When you get into biological threats, then suddenly we've got non-human data, some of which can actually be threatening to humans. So we need to add a different level of protection and guidance to the data sets. So we need to be aware of the various ways our data are used and understand how to build our resources to support the policies that drive the use of that data. I hope that answered your question. There's a lot of different ways we could go with that.
Thank you. That was perfect. Thank you, Dr. Brennan.
Thank you so much for going and delving into that complex navigation between AI policy and the NLM, and really highlighting, that depth and breadth of how it can be really overwhelming at times as well for everyone. So that would move us into our next student. I'd like to introduce T, and she's going to present her question as well.
Hello, my name's T. I'm one of the fourth-year medical students at McGovern Medical School, and I'm applying for residency right now in pediatrics. Whenever we are students, we are often trying to get quick, fast facts for things, and we use like Medline Plus to help educate patients and Stat Pearls to learn stuff for ourselves. But as a learner, it often feels like we're drowning in information with the new studies and the recommendations for therapies coming out so quickly. So how does the NLM try to combat the problem of information overload?
We probably contribute to it more than combat it, frankly. I'm sorry to say. So we do a couple of things. We partner with private groups to make use of our information in ways that make sure it's condensed and it's understandable. I'm particularly excited about what the large language models might be able to do in helping us convert our abstracts into lay abstracts so people can read them, or abstracts that people who are knowledgeable scientists but in other domains can read. Because right now, if you try to read an abstract about a particular gene structure, it may make no sense to you unless you know that gene structure very well. So learning how to engage with the user to present the material on the screen, if you will, or material in the summary in a systematic way that does not violate the premise of the material, but allows for better integration of it is really important. We are also doing that, frankly, when it comes to curating large data sets. Large data sets that are highly curated by specialty organizations become less useful to other groups, and yet they may, in fact, be quite useful if they were curated in a way that identified the multiple perspectives that one could look at the data with. Now, the other things that we're doing there, you heard one of our big pieces that we're trying to do to help with information overload is to use innovative tools such as relevance-based ranking to make sure we present to a user a request, or what we consider a patron, a search request in a way that's going to be most efficient for them to be able to handle this. We've explored presentation of abstracts in speech. Frankly, that doesn't work very well. The abstracts are too long and they don't convert to speech, but we did look at Alexa for PubMed at one time a couple of years ago. I'm glad you're finding PubMed, Medline Plus useful. That's a 25-year now investment that we've made to make sure the public, when they come to the NLM, gets access to generalizable information. What we do there, and this we hope is reducing the information overload, is instead of requiring a person to go to a different place for information about diet, about exercise, about diagnosis, they have a one place they can get that information in an integrated fashion. I would be very interested as we look into the future, though, to understand about what we think of as information in the moment. Many times our clinicians need not just to know, but they need to know what to do. And so the information in the moment piece is really a synthesis and then a set of actions. The Green Button Project you heard explained in the video is work of Nigam Shah's, and that's exactly designed to do that. It's to take a clinician who has a question in the moment and link them to library resources, the experience of other patients, and the wise advice by other clinicians so they can see trajectories over time. So most of what we're doing is investing in research and new ways of information presentation.
Thank you so much.
I love that idea and that concept of taking complex things, breaking them down, making it more usable, and making it something that even, someone like me, who's a trained pediatrician, is not going to be able to break down some more complex genomics as well.
Right.
So I'm going to move this over to Chase.
Hi, I'm Chase Hutchins, and I'm a third-year PhD student in the Graduate School of Biomedical Science. And we just had a question about the amount of information, and mine is kind of about the quality of information.
Okay.
So what do you think are the trade-offs between the rapidity of information dissemination through like preprints, like bioRxiv, and the full peer review process? Like what's good, what's bad?
This is going to tie a little bit to what my legacy is at the NLM. We believe that peer review, the society believes, scientists believe that peer review is the highest bar. Yet we know that 20% of the literature is wrong in some way. It's falsified intentionally, not too much, hopefully. It's got the wrong chart put into a table. It's missing a particularly important sign on a variable. So peer review doesn't always do what we think it does. So I'm not sure we can say peer review is the gold standard. At the same time, we have to remember that the speed with which new ideas are being generated and the speed with which they're being validated and debated is actually disconnected. So we haven't figured out how to speed up the validation and discussion pieces. We have figured out how to speed up the export piece. So the National Library of Medicine now does make preprints accessible through PubMed Central. We work very closely with several archives, but two big archives, with medRxiv and bioRxiv, and we only make available preprints from NIH-funded research, because that we have some assurance that the original design was considered valid and the original set of questions are considered valid. We tried a couple of years ago, Chase, to have a conversational approach to our PubMed citations called the PubMed Commons, to see if people would say, yeah, I read that article, but you should look at this other one before you make a decision on it. And frankly, we found that doesn't work. So what we're envisioning in the future is that small pockets of conversation will go on, and we need to support not only individual thinkers, but also those small pockets of conversation. So we're exploring different kinds of interface where a group think interface is presented, not just an individual requester of a phrase, but we begin to think about when a group formulates a question that might bring multiple perspectives in. That's a little bit hard to explain how that's happening, but a lot of our team science work is feeding into that now. And we're moving away from the idea of one person, one citation, to clusters of questions and people and clusters of citation. We have not yet cracked the way to make policymakers read articles, though. I can tell you that one right now. So what might be really useful is if we can do really good, effective work with training these large language models, we might be able to create this synthetic piece that makes a policymaker attend to it. Maybe we should put it in rhyming couplets or something like that, but something that'll help a policymaker see what we need them to see.
Yeah, well, thank you. And thanks for the great talk as well.
Thank you.
I love how we're looking at all the different aspects of that review process and how we can make sure that there are those checks and balances. So I'm going to go ahead and introduce Hannah.
Hi, my name is Hannah Cooley. I'm a third-year student from the UT Houston School of Dentistry. And my question for you all is, given consolidation in the publishing industry, what is the NLM doing to ensure the accessibility of our research, even open access?
When you say consolidation, I think what you mean is like the nature of things like that. Is that what you're referring to? Yeah. So we try to maintain as good a relationship as possible with the publishers. Why? They are our partners in producing our citations. The publishers send us the XML formatted citation information from the journal. And so we have to work closely with them as partners. At the same time, we have increasingly been unable to accept citations from journals that don't have the ability to create electronic XML formatting, which puts away some of our smaller journals and some of our specialty journals, and frankly, some of our third world journals. So we're looking at how do we balance the what is needed to create the record itself with the need to keep the literature broad. We are working with publishers. Publishers, as you well know, are not happy with the public access policy. The public access recommendation, or not recommendation, but the requirement from the president and the Office of Science Technology Policy is that within 3 to now 4 years, we will take down the paywall and we will not have paid journals. And so there are lots of questions that the publication industry is trying to figure out how will they sustain this large emphasis on peer review and their income stream. But what we are trying to do is to first and foremost work with the many ways possible to get the NIH's literature available quickly, and that's through PubMed Central. All NIH funded research, even now, is available within 1 year of the publication, freely accessible and permanently accessible. So we keep it available all the time. That's important also because the publishers, sometimes they close and you lose a whole history of publication. So we have a commitment to perpetual access and perpetual publication. We are also experimenting with, not us alone, but experimenting with the NIH and coming up with criteria for authors to publish and what constitutes a good journal. So we don't maintain a whitelist or a blacklist of journals, although I've been criticized many times for not having one. But in fact, what we do is we say to our scientists, if you're going to publish in a journal, pick one that has a good editorial board, proper ethics, it has a wide distribution, has a clear meaning and purpose in them. So we're trying to improve the targeting of publications, recognizing that we still have authors who, for lots of different reasons, publish in what might not be considered the top quality journals. And by quality, I don't necessarily mean the single word cell or chest, but I mean the journals that have research and reporting integrity.
Thank you.
Always important to promote integrity and high quality everywhere that we go.
Yep.
And I'm going to turn this over to Morgan.
Hello, my name is Morgan Foreman. I am a 5th year PhD candidate in the McWilliams School of Biomedical Informatics. And then I'm also a research scientist at IBM Research working on our generative AI solution, Watson X. My question I'm particularly interested in, which is, does the anti-science movement, and I'd also add in the anti-AI movement, we hear about every day, have an impact on the NLM strategic goals at a national policy level? And if so, what is the most effective way to mitigate those impacts?
The role of professional librarians in selecting and maintaining a collection is the single most important tool that we have to maintain a collection that is of the breadth and depth of scientific thought in society. We have to be sure that we are not privileging single perspectives, but rather making a broad attempt, which means many times that we have people, Congress people or everyday people who write to me and say, take that article out of there. It's terrible. It's wrong. It shouldn't have this in there. We have a preservation policy that says we do not remove articles from our repository, so they remain perpetually available for society. Now, we also provide expert consultation and technical support to groups like the National Academy of Medicine, who are working to develop the policy guidelines around science and science policy. What we have learned through the pandemic is that telling people scientists think this is a good idea is no longer a good idea, because the idea that scientists are viewed with skepticism. So we look for partnering with trusted partners in communication to make sure that the information that is presented in the way an individual can hear. I would say the NIH overall has made a shift in their communication strategy to say that instead of being an institution first or an enterprise first approach to communication, we're going to be an audience first approach. What does our audience need to hear and to learn about what we're saying? So taking the audience perspective and really understanding where the anti-science bias is coming out from and addressing the bias rather than giving more information to try to challenge the bias is a strategy we're taking.
Thank you.
Thank you, Dr. Brennan, for answering that question. We also have a couple of questions coming in through the Q&A. Dr. McKay had to hop off, so hi to everyone who's with us. Again, thank you for joining us. I'm Dr. Gomez. So I'm going to turn it over to Jessica, and hopefully we'll have some time to answer the two questions of the Q&A. Jessica, would you like to ask your question?
Yeah, sure. Thanks again for spending this time with us today, Dr. Brennan. It's been very insightful. I wanted to kind of leave us with, what do you hope your legacy will be as the director of the NLM?
When I came to the National Library of Medicine, our divisions were better known than the library overall. So we had the NCBI, or we had the Lister Hill National Center, and people thought of themselves first locally. And my legacy, I hope, will be a concept we call One NLM, that allows the entire library and frankly the entire world to see that the benefits of what we do come from this large different group of people, some who have technology knowledge, some who have curation knowledge, some who are experts in collection management. So that's my hope for the library, is to move it towards a One NLM model. My other two legacies that are really important to me, I've worked really hard to build to strengthen our infrastructure. We've put $40 million into making our building new. We've put $70 million into strengthening our computational platforms. And this is really great because we lived from the garage mentality, you know, the two guys in the garage building Apple computers, to the cloud during my lifetime, and rebuilding the NLM from a garage model, urgency first, documentation last, to a sustainable model has been really important. Finally, I trust that my legacy will be characterized by diversity of thought and plurality of participation.
Thank you. As a student, as a PhD candidate at the School of Public Health, focusing in management and policy, that is music to my ears.
Oh, thank you.
All right, so for our attendees, it looks like we're going a little over on time, so we understand if you're not able to stick around, but I'm hoping Dr. Brennan has a few minutes to maybe answer just the two questions we had in the Q&A, if you don't mind.
Sure.
So the first one comes from Elizabeth, and she wanted to know, how can we as caring scientists systematically improve our communication of our discoveries to the public in a trustworthy way?
So Elizabeth, what I would say is reach out to the people who you want to have listen to your knowledge and engage with them early, understand the terms that make sense to them, and map them back to the ideas in your own research so that you can show them how your science fits in with their scientific or clinical or everyday living questions. So early partnerships all the way along the research process, I think, is the way to go.
Thank you so much for answering that. And I know our final question comes from Nathan Carlin. So he asks, pharma sales reps see themselves as educating doctors about their products, but these presentations are conflicted. How does the NLM think about conflicts of interest?
Well, I come from a large family, I said earlier, and we have 4 drug detail people in my family. So I'm kind of up close and personal with this idea. As a federal body, though, the National Library of Medicine, as all federal bodies, believe that decisions should be made without untoward influence. And so it is absolutely critical to disclose the presence of influence, even if it's a personal salary, in the conversation that one is having. It's also been very essential for us to envision a future where the information needed by clinicians is as palatable, as accessible, and frankly, as fun to consume as pharma has made their information. They've for years employed legions of anthropologists to help make sure that they communicate to people in the way people need to be heard. And we're finally, I think, beginning to understand how important that is from a science perspective. The NIH and overall, and the NLM in particular, is absolutely opposed to conflicts of interest, whether it be in publication, the conduct of research, or the use of the products of research. And so, and to fulfill that policy perspective, we expect disclosure. We expect that the recipient of the information will have the right to terminate a relationship if they believe the influence is inappropriate for what they need done. And we believe it's important to educate the public overall that conflicts in and of themselves are not bad. They just have to be disclosed and managed.
All right. So again, I want to thank you, Dr. Brennan, so much for today's presentation. It was very educational. I hope all of our attendees, our faculty, our staff who were here today learned something new. On behalf of the Quality Enhancement Plan, to everyone here, thank you so much for joining us. We hope to bring you more of these campus-wide and school-based health policy forums. So we'll see you all again soon. Bye-bye.
Thank you so much for having me. Bye-bye.